I'm a primary care sports medicine doctor. I graduated from Philadelphia College of Osteopathic Medicine, then I went on and did a family medicine residency at Mercy Suburban Hospital in Norristown. And I did a sports medicine fellowship at St. Luke's in Bethlehem after that. I was in the Norristown area, East Norriton area for 3 years before I came here. I started here in July. Brand new building for Penn Medicine. Opened in July, just to talk a little bit about the building, where you are right now. Beautiful building. Half of it is constructed right now, this whole half. Downstairs we have radiology that has X-ray, MRI, eventually CAT scan, nuclear studies, ultrasound. We have a fully functioning lab back here and a coffee shop coming soon, which is nice. Second floor is all family medicine and occupational medicine, and on the third floor is mostly specialist floor. I'm up there with orthopedics. There's a few orthopedic docs listed here. Those are the Penn ortho guys who are coming out here now. Rheumatology is here, pulmonology with sleep medicine. Rheumatology, cardiology is here. We're doing stress tests, stress echoes, nuclear studies here now also. Allergy and immunology, and then also, there's one others that I'm missing. Urology is here right now. Eventually, next year, when the second half gets developed, we're going to have a fully operational surgical suite downstairs with 4 ORs. Eventually an infusion center, possibly physical therapy, which I'm pushing for, obviously. And then another thing is just more offices. Ophthalmology will probably be here too. So, let's see, what else before we get started? That's pretty much it. Outside, we have cookies, water. The handout you see here is just about one computer study that I'm going to talk to you about, but it's incorporated in my lecture. There's shirts and hats out here also. Feel free to take whatever you want, okay? So I'm going to move around a lot. Like I said, I'm a primary care sports medicine doctor. So what I see is mostly office-based orthopedics. I do non-operative musculoskeletal medicine. But I also have a big interest in concussions. Maybe because I had a bunch when I was younger, I don't know why, but I just developed a big interest in it. When I was at St. Luke's in Bethlehem, I was the team physician for Muhlenberg College, a couple high schools up there. When I was in the Norristown area, I took care of Gwinnett Mercy College and Kennedy Kendrick High School, which is now the new Catholic high school out in Royersford, Pope John Paul High School. So some experience so far. I've been out a few years. Concussions, obviously a very, very hot topic in the media right now. You all agree? Lots of concern with younger kids, obviously, high school, college, and it's even worked its way up to the NFL, where you've seen that they've put a lot of new rules into the sport, fines that we saw a few weeks ago for head-to-head shots. So obviously lots of concern. What I'm talking about today is, I'm going to talk to you about symptoms of a concussion, recognizing concussions, what we do to manage concussions, talk to you about the computer program that you have a brochure for there, talk to you about the future of what we're doing and kind of where we are overall with concussions. Some recommendations also, okay? If you guys have questions, just shout them out in the middle. There'll be time at the end for more questions also. So concussions, obviously a very common injury. Becoming more common, maybe, maybe not. Maybe it's just increased awareness of concussions. Maybe that's why the diagnosis numbers are going up. I've given this talk nationally to other physicians, locally at libraries and events like this. And before, my number always said 300,000 up there. And over the last few years, we've realized that that number is much, much higher. I've seen 1.8 million annually, and that's in sports-related concussions. Doesn't relate to car accidents or anything like that. Females are more susceptible to concussions. Much higher numbers reported in females, and I have a separate slide about that a little later on. Why is that? Is it because females report them more, or is it because they're actually more susceptible? Does it have to do with females' less strength in their neck, not being able to control their head? We don't know. American football, soccer, ice hockey, your 3 highest sports, especially in the high school and college level, for rates of concussions. Other sports have them, obviously. Actually, equestrian is very high on the global list of concussion rates. I never knew that until a year and a half ago. Almost 10% of high school athletic injuries are concussions. Depends on where you are. That came out of a study about 6 years ago, maybe. So what is a concussion? Well, the actual definition is this one on top here: a traumatic biomechanical force caused by a direct blow to either the head, face, neck, or somewhere else on the body transmitted to the head. I'm sure some of you saw the Eagles game where Deshaun Jackson got hit running across the middle. Mainly got hit in the chest, and you see his head snap forward. Perfect example of a blow to the body being transmitted to the head. Typically and usually, a concussion results in short-lived neurological symptoms that resolve spontaneously. Everybody heals at a different rate. Everybody suffers different symptoms from a concussion. And that's, I talk more and more about that in my talk here. So what is a concussion? It's a reversible, most of the time, functional change in the brain. It's not a structural problem. You don't see it on an X-ray. You don't see it on a CAT scan, an MRI. It's not a bruise on your brain. Some people believe that it is. It's not. That's a cerebral contusion, an actual brain bruise. That's a different type of injury. It's a functional problem. Your brain is made up of trillions of neurons that communicate with one another. For some reason, when you get hit in the head and suffer a concussion, these are the theories as to what's happening to the communication between all those neurons. Neurotransmitters might be getting spilled when they shouldn't be. Blood flow changes in glucose metabolism, how the cells are able to process what they're getting from your blood flow, which is one reason why we limit people's exercise in concussions, because your brain isn't ready for that increased blood flow, and it doesn't know what to do with that excess glucose and blood sugar. So those are some theories. Most of those theories come out of animal studies, literally lab rats being hit in the head, studying what happens to their brain, done over years and years of research. We obviously don't have any human studies as to what's going on for obvious reasons. Most of the studies that we have, and I'll talk a little bit more about those later, are imaging studies and then neurocognitive type studies, psychological type studies. Symptoms of a concussion. I can't look at this picture. Typical symptoms, I have a few of them listed here. These are some of your more common ones. Dizziness, headaches, very common ones. I feel foggy. I feel like I'm in a fog. Disoriented, nausea, vomiting, of course, sleep disturbances. Things that you commonly see. Do we have any athletic trainers here? No athletic trainers? Coaches? Any coaches? Okay. So, common things. I'm sure you've seen concussions before. You've heard of the story of the football player who's running the wrong way on the field after they suffer a concussion, or somebody who doesn't remember the plays, is in the wrong position on the field. Very common things you might see. Poor coordination and balance, slow to answer questions. Very important for an athletic trainer or coach to know their kids. When I cover a game or a team where I don't know any of the kids, it's harder for me to determine somebody's neurological status if I see them right after a concussion. Maybe this child is slow to answer questions all the time. Maybe they're not. You know, it's hard to determine. That's why it's really important for coaches and athletic trainers to know their athletes. And it's always great to have parents there. Parents can come down and say, my son's not right, something's not wrong, or something's not right. Poor concentration, inappropriate emotions also. I just recently saw a 12-year-old a few weeks ago who was in a skateboarding accident, landed on his head, and now his personality changes 6 weeks after his injury. Pretty difficult case for mom. Mom is beside herself, as she should be. He's getting neuropsychological testing. It's a big concerning case, obviously. Vacant stare, you can see it. Some people say, I can see it in their eyes. When you see somebody examining somebody on the sidelines, an athlete, and you're looking in their pupils, you're really not looking for a concussion. What we're looking for is a discrepancy in their pupils, how slow they are to react. If that's going on, you're more concerned about intracranial pathology, like a bleed in their brain, something more severe than a concussion. Let's see, what else? Decreased playing ability, also concerns. So a big one, does my child need a CAT scan? This is a very controversial topic. Most sports medicine doctors, even neurologists say that usually people don't need a CAT scan. But the big question is, a lot of people think, well, let's just be safe. We should get the CAT scan. But the problem is, if we CAT scanned every single person who had a concussion, we would probably increase the rates of brain cancer and other types of cancers from the amount of radiation that's in a CAT scan. It's high, a lot more than an X-ray. One CAT scan here or there is not too much to be concerned about, but if we're CAT scanning every concussion, 1 million of them every year, that's a lot of radiation out there. So when do you get a CAT scan? A few things to follow here. When you see somebody on the sidelines as a coach, athletic trainer, physician, whatever, key things that you're looking for, obviously, do they have any neurological deficits? Are they having a hard time moving their arm? Do they have tingling somewhere after this shot to their head? Are they weak somewhere? Do they not know where they are? Prolonged deficits. Severe, if their symptoms are severe, or most importantly, if they're worsening. Something you always have to do on the sidelines is see somebody, talk to them, and check them again 5 minutes later, and check them again 5 minutes later. If things are getting worse, that person needs a CAT scan without a doubt. If they have a bleed going on in their head, a subdural hematoma, an epidural hematoma, that bleed can slowly expand, and they're normal until it gets to a certain point where it causes pressure in the rest of their head. And that's when you obviously need a CAT scan. The hardest decision to make in those situations is who are the people who have a problem in their brain, a bleed, that's not causing major issues yet. And if we CAT scanned everybody, we'd pick those up. But we can't CAT scan everybody. That's the truth about getting CAT scans. So it's difficult. I personally, what I've been taught and what I do is I have a very low threshold to order CAT scans. I don't do it all the time, but if somebody's concerning to me and they don't fit the picture of what I'm used to seeing with concussions, they get a CAT scan. Absolutely. They go to the ER, get CAT scan. Another one, prolonged loss of consciousness. True loss of consciousness from a concussion is not very common, believe it or not. When I say true loss of consciousness, I mean unconscious, eyes closed, sleeping, no response whatsoever. Somebody who doesn't remember those first 5 seconds after a concussion, they're not truly unconscious if their eyes are open and they're looking around. Prolonged loss of consciousness from what you see in studies and guidelines is usually 30 seconds or a minute. If somebody is unconscious for 30 seconds, I'm concerned. My pulse is going up. My program director had somebody when he was a fellow who was unconscious for 10 minutes and went to the hospital and ended up being completely fine after that. Had a concussion, got through it after a few weeks. And I'll talk to you a little bit more about loss of consciousness. But anything longer than a few seconds is concerning to me. When I say a few seconds, I mean 4 or 5 seconds. If anything is longer than that, I'm concerned. It takes a lot of force to make somebody truly unconscious from a blow to the head. So, what do we do in the olden days of 1980 and 1990 and even early 2000s when somebody had a concussion? We graded their concussion. I'm sure you've all heard of grade 1, grade 2, grade 3 concussions. Where that came from was there were a ton of individual grading systems for concussions. Dr. Cantu is a worldwide leader in concussions. He had a set of guidelines. The American Academy of Neurology had a set of guidelines. Colorado guidelines were also made. Those were the top 3. But there were more than 27 different systems you could choose to follow. You could choose one of those to follow how you manage a concussion. And the problem is, each one of those systems, not one of them was based on good scientific evidence. They were all based on individual expert opinion, not consensus opinion, but individual expert opinion. So it caused a major discrepancy amongst providers, what we were doing for concussions. And as you know, when there's a ton of things for one problem, one of them is usually not the perfect answer, like cold medicines. How many cold medicines are out there? And is Dimetap the best cold medicine? No, because not one of them is the perfect answer. So that's what we usually did in the past. Somebody had symptoms for 10 minutes on the sidelines with amnesia, without amnesia, with loss of consciousness, without it. We gave them a grade. Grade 1s typically were out for 1 week. Grade 2s were out from anywhere from 2 weeks to a month, depending on what scale you were using. So that's the way things were done before. And I'll get into what happened to all those grading systems there. So to change gears a little bit, I'm going to talk a little bit about neurocognitive testing. IMPACT, as you all see in the brochures, is a neurocognitive test that was developed at UPMC in Pittsburgh by two very smart neuropsychologists. And what it is it's a 20 to 30-minute test where you're at a computer and it measures things like your memory, your reaction time, concentration, processing speed. It helps to detect subtle deficits in brain function. It's a great additional tool in the management of concussions. It's not the be-all, end-all decision maker for concussions. It's a great additional tool. If we didn't have this, everything is mostly subjective. Neurological exam, how somebody's feeling, how are they doing with exercise. This gives us some objective data. The best way to use it, and I have a couple others listed down here. Headminder and Cogsport are a couple others that are out there. IMPACT is by far the most popular. It may be because it was heavily marketed. I'm familiar with IMPACT. I trained in it. I used it during my fellowship. I use it now. From what I know of the others, it's the only one that has something called a symptom score, which I'll talk about. The best way to use it is to have a baseline comparison. I'm sure you've heard of people getting baseline tests. I'm sure some of your kids are at high schools who have IMPACT, and they use it on maybe to all their soccer and football players. That's the best way to use it. A baseline test is done before a season. In high school, usually your freshman and junior year. And it gives us a baseline. So if you have a post-injury or a concussion, you have a post-injury test to compare to that baseline test. Unfortunately, baselines aren't always done, but there is some normative data that's available through IMPACT. It's based on age and gender. Usually the way you compare, or the way you determine if somebody's data is abnormal or not, is you compare it to people their age and their sex. Another way to look at that is what's their GPA? What kind of student are they? Are they an AB student? Are they a BC student? And you can kind of base what you would expect them to do in IMPACT. Nothing compares to having a true, accurate baseline test to compare things to, though. And like I said, it should not be the sole basis of management. So the first part of IMPACT is this. First thing the program will do is have the person answer questions about symptoms. It goes over this big laundry list of symptoms right here. And they have to assign a score to that symptom, okay? Very, very helpful, because I can't tell you how many times I've gone through this list with somebody in my office and said, do you have sensitivity to light? Do you have a headache? Do you have this, that? No, I'm okay, I'm okay. And then they do this test, and they end up scoring like 30 after putting in all the numbers. So it may just be a matter of communication and somebody not listening to every word I'm saying, or me not asking all these questions. This helps to confirm that everything is asked and assigned a proper score. This can also be used then to compare in subsequent visits after that. What's their actual symptom score, and is it decreasing? Because it may be hard for somebody with a concussion to say, yeah, I don't think the lights bother me as much anymore. So now they can assign a score each time. So I'm going to get into the individual studies. I think there's 7 different sections of IMPACT. The first one here is word discrimination. And what the program does is it'll flash words on the screen. I think there's 12 words. Flashes it for a few seconds, and you sit there and watch. And then at the end, it asks you, well, small one of the words displayed. And if it was, you click yes. It measures how quickly you press yes. Was it correct? Yes or no? If small wasn't one of the words, it might ask, or even if it was, it may ask you, was smell one of the words? Was tall one of the words? Was large? So it tries to confuse you. And obviously, if you have a concussion, this is not an easy thing to do. Same thing with designs. This is extremely difficult to do, especially when you have concussion. This design might be, they'll flash different designs, and then it might be flipped around. This arrow might be shorter, flipped around upside down, backwards, different type of design. You have to remember what that design looked like. Another thing that the X's and O's, yes. Another thing that the test does is it makes you remember 2 things at once. Not easy to do when you're talking on the phone and driving at the same time, or texting. So this test, what it does is it flashes up a screen full of X's and O's, and 3 of the X's will be highlighted yellow, and you have to remember where those 3 highlighted X's are. And we'll move on to this, where it'll flash a red circle or a blue screen or a blue square on the screen. You have to click the left one for this and a right one for that. And you do that for 30 seconds or so. Then you go back to the screen with the X's and O's and have to remember where those 3 X's were. Not easy to do. I took this test when I was a fellow, when I didn't have a concussion. It was difficult, very difficult. Symbol matching. First, there's a learning process involved in this where they go through 27 rounds of literally putting the symbol there, click the corresponding spot. You go through all those rounds, and then what they do is take away all of these symbols. So you have to remember where those individual symbols were. An accurate test, this one, the color match, is an accurate test for reaction time as well as something called your response inhibition, or your impulse control is another term for it. And what that is you know that you're trying to do something as fast as you can. However, when you're doing that in your brain and you're clicking as fast as you can, what is your ability to inhibit yourself from actually clicking that mouse? And that's what impulse control is. So this test, you can see it's explanatory here. I think this is the last, yeah, I think this is the last one. So 3 letters. What the program will then do is flash 3 letters up on the screen, A, P, L, and you type them in. And you have to remember those 3 letters. I'll move on to this screen, you click backwards through all the numbers, and at some point it stops this, surprisingly sometimes, and asks you what those 3 letters were. So again, making you remember 2 things at once. So in the end, after you do all these things, the computer program mushes all the data together and figures out a whole bunch of composite data. And what you see is a report. This is an old style. This is the original style of impact. Now it's newer, and there's a symptom score incorporated with this. And this is a typical response for what you see in somebody who recovers from a concussion. I know these numbers are not very easy to see. Here's a baseline done on September 4th, 2002. Somebody in the 96th and 78th percentiles for memory, verbal, and visual. A speed composite, a processing speed composite of 32, and a reaction time of 0.5. An impulse control of 7. An impulse control of 7 is usually how many errors somebody makes with the red-blue changes or missing an X. Anything below 9 is considered normal. Above 9, you start to wonder, was somebody not paying attention? Were they doing it too quickly? So you see now post-concussion, concussion happened on 1/27/03, now tested on the 28th. And you see how their memory percentages go down. Processing speed is down. Their reaction time is now up to 0.6. I don't care who you are, you're not going to be able to measure somebody's reaction time with a stopwatch accurately, as accurate as this does. Impulse control of 120. This person was sitting there clicking things, not realizing they were doing the wrong click the whole time. And now you see over a matter of a week or so, their numbers start to improve. And now 8 to 10 days, or 9 days or so out, now their numbers are back to a relatively normal range. What the program does is it compares your tests here to your baseline and uses something called a reliability index. And what that is basically 1.5 standard deviations away from what your baseline test was. So when something is abnormal, it's highlighted for us dumb doctors to say, oh, okay, well, there's a highlighted number, that's wrong. Symptom score, very, very helpful. You might see a symptom score of 52 on this one here, and then out to 10 and down to 1 or 0 here. There's a breakdown of the individual correct and incorrect answers that we see with the report, and it's helpful. So neurocognitive testing, like I said, provides great objective data. Very, very helpful. The problem is it's not a perfect test. It's a lot better than what we had before, which was nothing. There's a thing I did want to mention. There's other tests too, other than the computerized tests. A lot of neuropsychologists use paper and pencil testing. There's an array of tests that they can use for that. It takes a lot longer to do. One of the first in the area that were doing that were the Philadelphia Flyers, actually, who were doing paper and pencil testing on their athletes pre-season. For 2 hours, they'd have to sit down and take a battery of tests. So like I said, not a perfect test, and there's a number of reasons why. What is an accurate baseline? Most baselines are done now in a computer lab. It's the practical way for a high school or a college to get it done. If you have a college and you're 500 athletes or something, or Sinus College has 600 athletes, they put 20 to 30 kids in a computer lab. They sit every other seat, but that's how they take their test. Number one, do they explain why this test is so important? You need to try your hardest. Don't sandbag the test. Don't sit up there and try to make incorrect, or take your time and do incorrect answers on purpose, so that when you take your post-injury test, it looks okay. There's ways to tell when somebody's doing that when you look at the raw data. Are the baselines evaluated to make sure that they're valid baselines? I had somebody in my office a few weeks ago who had a baseline test done where one of her numbers was less than 1%. So a very smart student, but why was that number like that? And she most likely made some mistakes on her original test. So practice effects, definitely a known factor with taking this kind of test. People get better at it. The test itself will change which words you use, which designs you use, and things like that, and the letters. So that does help, but people get better at it. And the results are affected by a lot of different things, not just a concussion. Is somebody sick that day? They have a lot of stress that day. Did they just take 2 tests? Is it midterm time? So there's other things that affect how somebody's cognition is working and how quickly they can process things. Another thing I use, and I threw this in here because I had it in a separate section where it shouldn't be, is balance testing. Something I use, which a lot of physicians who deal with sports-related concussions do balance testing. It's called the BESS, B-E-S-S, Balance Error Scoring System. And what you do before the season, you can use a baseline and then a post-injury evaluation, is you have somebody stand in different positions. Usually it's hands on your hips on one foot and then one foot in front of the other. You stand there for 20 seconds with your eyes closed, and you do the same thing with your eyes closed on a foam pad that's about 1 inch thick. And you measure how many errors they make. An error is if they take their hands off their hips, if they open their eyes when their eyes are closed, if they flex their trunk more than 30 degrees to remain balanced, or if they jump out of position. It's an error every time. You sit there and make a check mark as you're watching your watch. And you can see, typically within 3 days after a concussion, people's balance and motor skills get better if they have a deficit there. But there's been times where I've seen people a month out where they still can't balance and they're just not ready yet. And that goes back to everybody is an individual. We all heal differently from concussions. We all have different symptoms from concussions. So when neurocognitive computer testing came out, it made things a lot easier to do research because you now had this tool that gave you some objective data. And there were some pretty landmark studies in concussions that came out around the late 90s, 90, 99, somewhere on here, 2003, 99, 2003. Dr. Lovell, who's in 3 of these studies, was one of the creators of IMPACT. He's one of the neuropsychologists there, him and Mickey Collins. This first study in the top left, grade 1 or DING concussions in high school athletes. What they did was they looked at grade 1 concussions, which in some guidelines, if you remember those grading scales I talked about, allowed people to go back into a game in 15 minutes if their symptoms went away. I didn't mention that with the grading scales. So they looked at grade 1 concussions, where a majority of them went back into a football game. This was all high school football players. And what they found on impact testing and measuring people's symptoms with impact is they had symptoms and cognitive deficits 36 hours after their injury, still suffering from that concussion 36 hours later. Yet, with these guidelines that we were following, these grading systems, they were allowed to go back into the game in 15 minutes. It showed that the grading scales were too liberal. A number of them were. Another study by Kevin Guskowitz down in North Carolina, that there are cumulative effects associated with recurrent concussion in collegiate football players. That's what he studied. And what he found was, I think he studied I just looked at the study recently, I think it's 197 football players and followed them for a few years. And what he found was the ones who had a concussion in the past took longer to recover from another concussion in the prospective study, and they took longer and they had more symptoms. So that's concerning right there. Shows that there's some amount of accumulation from these injuries. For some reason, people are taking longer and having worse symptoms. Dr. Level had another study. This one was huge. Can still have a severe concussion without loss of consciousness. So many of the grading scales were so heavily weighted in loss of consciousness. There was one where if you had symptoms that lasted less than 15 minutes, it was a grade 1. Grade 2 was symptoms for more than 20 minutes without loss of consciousness. And if you had loss of consciousness, it bumped you up to a grade 3. So it was very heavily weighted on just loss of consciousness. And what we found is that people can get knocked out and get better in a week, even if they're knocked out for 5 to 10 seconds. But there's people who don't get knocked out and they take 6 months to get better. So you can't just base everything on what happens right at the time of a concussion. Now, to talk about that, there's one thing that it would be great if, as physicians and athletic trainers and everybody else seeing a concussion, if we could determine somebody's prognosis right away. It's great, so you can tell the athlete, tell the parents, they'll probably be better in a week or 2 weeks. And one thing we're looking at that shows some promise is actually retrograde amnesia. Amnesia is obviously you lose memory of the event. Retrograde means that you don't remember things that occurred before your injury. Anterograde means things after your injury. And there's been a couple studies that show that people with retrograde amnesia at the time of the injury seem to take longer to recover from their concussion. So that's something that's coming up, something promising so that we can establish a prognosis. Dr. Lovell had another one where he showed that recovery in mild concussion in high school athletes, symptoms typically resolved in 4 days on average, but their memory deficits lasted 7 days. So people were feeling better, but they still had cognitive issues still going on. Memory issues was the main thing. He saw an insignificant difference in reaction time. There was a difference, but statistically it wasn't significant. So based on all this research that came out at that time, and that was just 4 of the studies, there were tons of studies that came out. There are 3 big meetings that occurred. One in Vienna in 2001, Prague in 2004, and then the last one, Zurich, in 2008. And this was called the International Symposium on Concussion in Sport. And it was a meeting of sports medicine doctors, neurologists, neuropsychologists mainly. And they all came together and said, look, there's so much going on in concussions right now. We're learning more and more about it. We need to establish guidelines. We need to figure out and put all of our heads together. And the first thing they did is they said no more of these grading scales. We can't use these because everybody, like I said, heals individually. And we can't establish prognosis, so the grading scales aren't helping us at all. They also said to be more conservative with children. And the reason why is because children take longer, the younger you are, the longer you take typically to recover from a concussion, which is odd because most things, kid breaks their wrist, they're better in like a couple weeks. Me or one of you guys breaks our wrist, it takes us 4 weeks, 6 weeks, whatever. Kids usually heal faster, but kids' brains are still very pliable. They're still forming connections, and for some reason they take longer to heal from concussions. Obviously, be more conservative with children because you don't want to make if they have an injury, remember they still have to create connections in their brain to learn things. So you don't want to halt any of that learning process, obviously. Cognitive rest. This is a huge one that came out of these meetings. The first thing we always recommend is physical rest. Okay? Shouldn't be running, shouldn't be biking on a treadmill, whatever. Cognitive rest is relax your brain. When you concentrate, you have to use your brain. And remember, these neurons in your brain are injured. They're not working correctly. They can't handle the blood flow going to them, like I said. When you think and you concentrate on something, different areas of your brain receive more blood flow and have more activity in them. We've seen it on functional MRIs and all sorts of studies. Cognitive rest means no video games. Don't sit there and text for 2 hours. Don't surf on the internet for 3 hours. Tests in school, projects in school, presentations you have to get ready. Kids seem to, well not kids, but anybody, any kind of athlete, seem to have prolonged symptoms when they have to concentrate more and more. Very, very common after a concussion for somebody to have to study, like a college player, a college athlete who has a concussion, and now they have 3 midterms, and they just keep getting headaches with with studying. Something that we do is we recommend cognitive rest. If I have to, I pull kids out of school for a few days, allow them to rest. There's a hard balance with that, though. I can't pull every child out of school and say you need to miss 2 days. So what I do is I allow somebody to go back to school and take their classes, and if they report to me that they're not doing as well, they're having a hard time, they're having headaches after every time they study, when they pay attention in class, then what I try to do is talk to the teachers, push a test off for a week or two, allow them to heal. A big thing that I've seen help a lot is allowing an 8th grader or a 9th grader 2 times a day, once in the morning, sometime in the afternoon, to go down to the nurse's office and lay down in a dark room for 15 minutes. Just a rest time for their brain to relax. And I've recommended that to a lot of people, and it helps, significantly helps. Video games are the biggest thing, without a doubt. No video games. So the symposium also recommended neurocognitive testing, mainly for the more complex types of concussions that are taking longer and longer. And the biggest thing that came out of here was no return to play on the same day. No more. Nobody should be going back in the same day. And you've actually probably have seen in the media and the news that a number of states have actually made laws about this now. Washington, I think, state of Washington, I think, was the first one. I think Illinois or Indiana has it now, and it's actually on the tables in Pennsylvania. Not officially a law yet, but it's being voted upon. The law is that somebody needs to be evaluated by a physician before they can return to play. If a coach or an athletic trainer or another physician documents that they have a concussion or is concerned about it. So another thing that came out of the symposium is a recommended guideline for a return to play, a stepwise return to play. How do you get somebody back to their sport or their activity? And the key thing about returning to play is you need to pass a few things. Number one, your cognition has to be normal, whether it's through impact or whether it's through somebody assessing it with a number of questions. There's a set of questions called Maddox tests. There's a SCAT card that some coaches, athletic trainers, field physicians use. And that's the first thing you need, a normal neurological exam, of course. They have to be asymptomatic, no more symptoms, at rest and at full exertion. Not running for 5 minutes, full exertion. So what we do typically is push somebody through these different steps. Number one, rest, no activity, nothing. And if you need cognitive rest, we do it. Once they are asymptomatic for 24 hours, push them on to step 2. Step 2, a little bit of exercise, okay? No resistance training yet. You're just testing out the waters a little bit. You're pushing a little bit of blood flow to the brain. They pass that, the next day you move on to sport-specific exercises with a little bit of resistance training. Now you're moving blood flow more. That's all you're doing at this step. Now in step 4, you're adding drills. So not only are you increasing, you're making them do endurance, but you're also throwing in concentration with it. So you're testing not just how their brain handles more blood flow and the physical activity, but can the brain concentrate and do things correctly while in an exertion state. And then the 5th step is usually to get back to a full contact training or practice. And what that does is allow somebody to establish confidence, that they feel okay when they're out there running into their teammate. If they're doing a drill in football or soccer, they're okay running around with their teammates. There is a huge difference between contact in a practice and contact in a game. A huge difference. With contact in practice, you typically know your hits are coming. You know what's coming at you. You can prepare yourself. You can clench when you need to. You can tighten your neck muscles. In a game, anything goes. You don't know what the other person's going to do. So that's the big difference between step 5 and step 6. If somebody becomes symptomatic during one of these, they drop back a level. And this is the typical process for what happens for most concussions. I'd say 85% of concussions follow this. And most people, whether you're 15 to 25, your typical college to high school to college and just after college age group, usually gets better in about 7 to 14 days, somewhere between 1 and 2 weeks. And you can follow this guideline. It's pretty simple to do that. But that doesn't always occur. Like I said, and I'll say it again, we all heal differently from concussions. So repeat injury. Tons of evidence out there to support, and there's also some evidence to refute that there's actually accumulative effects from concussions. More and more evidence shows that there's accumulation. And it's mainly in people having possibly permanent issues, but mostly that people have prolonged symptoms and worsening symptoms with repeat concussions. And the biggest difficulty is finding out who are the people that are more susceptible to having the cumulative effects and possibly, like I said, the permanent effects. And there's a few things that we've learned over the years as to who might be more susceptible to that. One is something called ApoE. It's a genetic allele that certain people have. There's studies done years ago on boxers. Something that some boxers developed was called chronic traumatic encephalopathy. You can actually see it on an MRI, degeneration in their brain. The ApoE4 allele is a certain genetic marker, and what they found is that people who had a certain type of this certain type of genetic allele had a higher risk for having things like Alzheimer's and prolonged symptoms from concussions and chronic traumatic encephalopathy. So that shows some promise as a possible marker where we can do blood tests. Possibly in the future we can do blood tests on people and say, you might be more susceptible to a significant concussion, so if you have one or two, we should call it quits. Or maybe we'll get to a point where we can do blood tests and say, you probably shouldn't play. But that's a whole other topic and obviously could be controversial.
But wait a minute, on that topic, that's CTE, right?
Yes.
A lot of information has come out over the last 6 months on that, saying that they've tested quite a few football players.
Yes.
And they couldn't test them while they were alive. They had to wait for them to die.
That's not the ApoE allele.
That's different.
That's different, yes. That's to look, and I'm going to talk about that. That's to look at plaques in your brain, and I'll talk a little bit about that. You're right, though. Another thing is migraines and motion sickness. There's been one or two studies on migraines, and I think one on motion sickness, that people who have history of either one of those possibly could have prolonged symptoms. No good data, no hard data on that where the study's been repeated over and over, but it's out there. We're looking at that. Another thing that we're obviously concerned about is something called second impact syndrome. Has anybody ever heard of that before? No? Second impact syndrome is when somebody has a concussion and they're suffering from that concussion and they suffer another concussion. When you are suffering from a concussion, your brain has a lower threshold to suffer another concussion. And when that happens, you can, and there are probably somewhere between 50 and 100 documented cases of this over the last 4 or 5 decades. So it doesn't happen often. You can develop rapid brain edema, where your brain for some reason swells, and people can have permanent neurological issues and die from it. There was a case, I forget where it was, not too long ago, where they were concerned about this being the cause of a high school player's death. You've probably, if you've seen any documentaries on the news about concussions, they always go to a case where somebody had what they think was second impact syndrome. A lot of neurologists, neurosurgeons don't believe in it. They think that there's another process going on, that it's actually from a subdural hematoma or something. But there have been cases where nobody knew exactly why, but for some reason developed rapid brain edema where they needed a craniotomy to allow the brain to not swell under pressure. And people can have permanent neurologic problems. That's the biggest thing we're obviously trying to avoid when we keep somebody out of a football game right away. The most important thing is to allow each concussion to heal. And because of second impact syndrome, but also because, like I said, when you have a concussion, your threshold for another one is lowered, okay? And the concern is, and I have another slide about this just to talk about it now, there's a concern that there are certain people who have a lower threshold for concussion. And when you suffer a concussion, do you always have a lower threshold for the next one? That's the theory that's going on now for the reason of accumulating effects. So when to retire, when to stop a season, when to retire like these folks, when to pull somebody from a sport. There's no hard and fast number. There's an unwritten rule that's been around, say if somebody has 3 concussions in a season, they should end their season. Well, I think the most important thing to do is to look at their subsequent concussions. Are they coming from less and less force, meaning that they have a lower threshold for a concussion? And also, what are their symptoms? Do they have longer and longer symptoms after each one? Even if it's 4 over a month or a couple months or 6 over 6 years. What's happening with their history? And lastly, how is it affecting them, especially professional athletes, because they're the ones who, this is their living. They're making millions of dollars, but maybe they didn't go to college and maybe they don't know what to do if they retire from football or whatever. They're always pushing the envelope as to, I need to get to that point where I can play, but if I have one more, I'm done. So nobody knows where that line is, where to decide it's time for you to end. And unfortunately, a lot of these people up here got to that point where they have had nearly permanent symptoms from repeat head injuries. So the key thing is, and what I use when I see somebody with repeat concussions is, are you suffering more and more concussions from less and less force? And are your symptoms lasting longer and longer? Whether they're permanent or not, my big worry is that 17-year-old junior soccer player going to take one more severe concussion, and now maybe they'll just have migraines for the rest of their life, or maybe they'll have memory loss for the rest of their life, or will they end up being one of those second impact syndrome people? And that's obviously what we're trying to avoid. So, yeah.
Is second impact syndrome diagnosed when junior is present?
Yes.
Okay.
Yeah. It's
So that's different than repeat injury.
correct. It's something that can occur from a repeat injury. It's a very severe condition that can occur. Doesn't happen to everybody. Like I said, there's only been a few cases reported over the last few decades. So post-concussion syndrome, defined as somebody who has persistent symptoms linked to a concussion for more than 6 weeks. Most of the time, people who reach that 6-week mark, most of the time, eventually their symptoms do go away in 3 to 6 months. And that's if they're held out of their sport and they don't suffer another injury or something. The main treatment for this, and to hint on this now, there's no treatment for concussions right now. There's management for concussions. No treatment though. We don't give a pill. We don't send them to a certain therapy to make things get better quicker. When that comes out, that'll really be scrutinized, and if it does, I hope it comes soon, because it would be a great thing to use for all these people who are suffering concussions, obviously. Rest, obviously, but a gradual return to exercise. Something that's been shown recently in the last few months is people who have started a slow, gradual exercise program at 6 weeks after an injury tend to get better quicker than those who don't start an exercise program. So that kind of goes against what we do acutely after a concussion, but when somebody is suffering from headaches repeatedly over 6 weeks, maybe they're getting better and better, you try to have them do some amount of graded exercise. And what I do in that case is I literally start somebody on a 1-hour walk. They go out for a walk, and maybe 3 or 4 times they run for a few minutes, and they run at 25% what they can usually run. And you slowly build that up over a course of weeks and weeks. And people's symptoms, based on the studies, seem to get better quicker than the people who don't do that exercise. Modified daily activities and schoolwork. These are the kids who might need rest time, morning and afternoon, for the next 2 years or something. They might need additional tutoring because they're having a hard time remembering things. Post-concussion syndrome is a major, major problem, especially in high school and college kids who are in their biggest time of learning in their lives. Medications for sleep problems, pain, muscle spasm, depression, headaches, etc., etc., etc. That's where people are on medications for concussions, when they have post-concussion syndrome and you're trying to control the symptoms from post-concussion. That's not making the post-concussion syndrome better, it's managing their symptoms. So prevention of concussions. There is no evidence that any protective equipment available prevents a concussion. Okay? The one thing that came out that was somewhat promising was one study on this new type of Revolution Riddell football helmet, which probably, I don't know what percentage, but more and more high schools and a lot of colleges now have that type of helmet. Riddell is one maker of helmets, Shoot is another. Shoot just recently came out with a a design. Deshaun Jackson actually bought one for $300 or $400, which they claim, based on independent research, can prevent concussions. So most of the studies show that no protective equipment out there can prevent a concussion. Football helmets were developed years and years ago not to prevent concussions, but to prevent facial injuries and skull fractures and subdural hematomas. And what happened when we put football helmets on people? Does anybody know what injury rate went through the roof when they first put neck injuries, right? Because it became a weapon. And when somebody does this with your neck is supposed to have a backwards curve like this. But when you do this and lower your head, your neck now it's perfectly straight. And if you take a curved piece of plastic and go like this, it bends, right? It bends like that. If you take a straw and do this, a straight straw, it cracks in the middle. That's exactly what happens in the mechanics of your neck when your neck is down like this. So that's another reason why we have rule changes. You're not supposed to spear in football. When you hit somebody in football, what coaches and athletic trainers and everybody teaches you is see what you hit. You don't hit like this, you hit like this. So you see, you hit with your face, you hit with your upper chest, your arms, your body. Rule changes have been very, very helpful in decreasing concussions. Now, like I said before, you've seen it in the NFL, decreasing those head-to-head hits, direct head injuries. Something I saw recently is NFL quarterbacks have been protected, and some people think overprotected, for the last 5 to 10 years. Concussion rates in NFL quarterbacks have dropped significantly since those rules have been implemented. It changes the game, absolutely it does, but it's helping to protect people. Another one is in hockey. Hockey now, at all levels, has strict rules on direct head contact. And I heard somebody recently say about the fines and the suspensions. I think, actually, it may have been, did anybody read the Sports Illustrated thing with the concussions that came out a couple weeks ago? It might have been in there, where somebody said, you can fine the players all you want for doing a head-to-head injury. You can fine them $10,000 or $50,000. I think it was Mike Shanahan, actually. And he said, if you really want to have effect, suspend the players. Take them out for a week or two. Fines to somebody who makes $5 million a year doesn't make a big difference, obviously. So again, another thing about protective equipment is most evidence shows that mouth guards do not prevent concussions, even custom mouth guards. A lot of dentists, and I apologize if there's any dentists in here or anybody who believes this, but most evidence shows that even custom mouth guards don't prevent concussions. And it makes sense, unless if you're getting hit in the jaw. I understand the whole theory of you can clench down and help protect your neck muscles more, but if you know the hit is coming, you're usually less susceptible to a concussion. Most concussions we see as we look at videotapes, it's because somebody didn't see it coming, just like Deshaun Jackson. I'll go back to that one again. So it kind of makes sense that a mouth guard won't really help you if you don't see it coming. Unless if you get hit in the jaw, maybe it'll dissipate some of the forces. Education is obviously paramount. We need to educate people just like I'm doing today. Educate parents, players especially, to recognize what a concussion is, what's happening to you, the importance of recognizing it. Coaches, trainers, again, get people to realize how severe these things are. Back to females versus males. Like I said, females have a higher prevalence, a higher risk for prolonged symptoms and more symptoms at the time of injury. Is it, like I said, because they can't control their heads better as well as males? We don't know. Is it just because they report more symptoms? Females are usually more honest in the high school and college time frame. They also show, females versus males show some differences in verbal memory versus visual memory on the impact test, so that's kind of interesting. Future management. I have a couple more slides here. Future management, there's lots of things out there. Functional MRI is one that's becoming promising. The problem is there's few places that have functional MRIs. Most insurances won't allow you to go get a functional MRI with just a prescription. It's a big deal to get it done. But it's looking promising. This is an example of a functional MRI. It shows brain activity and increased blood flow in certain areas of your brain. And there have been a number of studies, and there was one in Sports Illustrated that actually used functional MRI. And on my next slide, I talk a little bit about that. Some other things, like I said, the ApoE promoter genotype, that's certain allele, possibly linked to having a history of concussions, especially more severe ones. Some other things, some other serum markers that have come out. There was another article in the Sports Illustrated that talked about the United States Army doing research on people with concussions. And they have a certain blood marker where they can see that somebody had brain injury after an event, whether it was a roadside bomb or falling or whatever. And it shows some promise that we're finding individual things that are spilled into our blood from neuron injury that we can actually determine, did you or did you not have brain injury? The problem with that study for sports is that's all done in moderate and severe traumatic brain injury, not concussions. There's a difference. Concussions are nothing like somebody who has a subdural bleed or has persistent loss of consciousness after a roadside bomb or something like that. So there's a big difference between the two. And really important that you realize we are really in the infancy of what we know about concussions. And on top of that, really about what we know about the brain. A perfect example to this is I was talking with the pulmonologist here, Ron Barnett, last week. And I don't remember how we were talking about it, but he said, you know, back in the 1950s, when somebody had a heart attack, do you know what we did for them? They were in bed rest for a year. We didn't have angioplasties, we didn't put stents in or anything like that. And I obviously wasn't around then, but that's how we treated them. And if you look at us now, maybe in 30 years we're going to say, man, do you remember when we saw concussions and all we did was keep people out of activity and tell them not to play video games? We didn't give them this medicine or have them do this therapy or whatever it is. Who knows? Hopefully we get to that point where we can actually treat these things. So it's important to realize we're probably in the very beginning of what we really know. So the recent research, I'll talk about the cadaver studies first. There's a group in Boston, I can't remember the leader's name right now, unfortunately. But what they're doing is they're looking at cadaver brains, mostly from athletes, professional athletes, some college athletes also. And they're looking at their brains to see what has happened from repetitive injury. Most of the cadavers that they have are people who have had injuries. They don't have a lot of cadavers of people who have played football or other sports with repetitive head injury and haven't complained of symptoms and diagnosed with concussions. So they mostly have people who complained and were diagnosed with concussions. And what they're seeing, though, like you mentioned before, is there's Alzheimer's disease. Something that happens in Alzheimer's disease is you develop something called plaques in certain areas of your brain, tau protein plaques. And there's no way, if any of you have relatives who have Alzheimer's, there's no way to absolutely, definitively, with a test, diagnose that somebody has Alzheimer's while they're alive. There's no blood test. There's some changes on MRI, but it's not always consistent with Alzheimer's. And that's how she mentioned that. That's why she mentioned that. That's why they can only do this on the cadaveric studies. You see these plaques. But what the concern is, there's changes in these players' brains where things are more consistent with Alzheimer's, with ALS, with CTE, chronic traumatic encephalopathy. And it obviously is concerning. And the question is, though, are these people who are diagnosed with concussions, or are these people who are suffering repeat sub-threshold, sub-concussive blows? Is it anybody who plays a sport where you're constantly getting your head banged around? Or does it happen to everybody? Who knows? At some point after you die, we don't do autopsies on every single person, but at some point, does your brain deteriorate? Are we just seeing Alzheimer's changes? But this is obviously very concerning, and we'll see over the next probably 10 years or so, as they get more and more people who donate their bodies to this, we'll be able to determine that this will really help with determining are there really accumulative effects with these concussions. Another study that was talked about in the Sports Illustrated was also very concerning. What they did was they looked at a number of high school athletes and they put them into categories. And what they did was they did functional MRIs on them, and they also did, I believe it was impact they used. They may have used another neurocognitive test. But they looked at people who complained of concussions and people who didn't. or were diagnosed or complained of symptoms, and they put them into groups. There were people who had no concussion history, no symptoms, and had normal cognitive testing and a normal functional MRI. And then there was a group who complained of symptoms, maybe were diagnosed with a concussion, had abnormal cognitive studies, and had an abnormal functional MRI. But then there was a third group that didn't complain of a thing, and they had abnormal cognitive studies and abnormal functional MRIs. So they didn't realize it. They didn't know. They weren't complaining of headaches. They were never diagnosed with a concussion. And the big question is are these repetitive subconcussive blows causing issues? And not just the kid who gets blown over on the sidelines with a huge hit. Maybe that's not the only one we should be worried about, the one who has an obvious concussion. Maybe we need to look into the lineman who has 3,000 subconcussive hits to his head over the course of 6 months or 4 months. That's where this is leading us now. And are there short-term, long-term implications to this? Most of those people who were in that study, who were in that third group, and even the ones who had a diagnosed concussion in the second group, their functional MRIs and their impact tests, their cognitive tests, went back to normal after the end of the season, after they recouped. But the question is, are they back to 100% normal? Are they back to 98% normal? We don't know that answer yet. Are there long-term implications to that? Are these the people who end up with depression in 30 years, who end up like Andre Waters in the one picture there, committing suicide from depression, where it's possibly linked to chronic traumatic encephalopathy? Like I mentioned before, the blood test for brain injury, the cadaver studies. And again, the concussion threshold is the theory that each one of us has a different threshold for a concussion. And the interesting thing about that is Doug McKeague is a gentleman from Australia who's a sports medicine doctor who is in the international symposiums and has done tons and tons of research on concussions. And one thing he proposes as a theory is that not only do we each have individual concussion thresholds, but other things affect our threshold. If you're dehydrated, if you've been sick, if you have a lot of stress, maybe that lowers your threshold to make you more at risk for suffering a concussion. So that's another theory we're looking into. Like I said, we're in the infancy. We don't know exactly right now. So overall recommendations I have for you. Number one, I think impact or any other study that you use is a great tool to use when managing concussion. It's not the answer. It's not the perfect answer to making sure people are okay, but it's a great additional tool. Typically what we do is right now impact is available for 11 years and up, 11-year-olds and up. There is a pediatric version which is almost done. That's, I believe, going to be 5 or 7 and up. 11 to 13, you should get one baseline done every year because your brain is changing so much year to year. As you get a little older, usually it's every other year after 14. What most high schools do is freshman year and junior year. Colleges, some do freshman and junior, and some also just do freshman year. Right now, I'm getting impact in my office soon. I had to go through a whole bunch of legal stuff with the whole Penn system, but everything is done and I should have it here soon. So what we're going to do is offer baselines. We don't charge your insurance or anything like that. You come in for a baseline, you do it in the office, $30 right now. 30, we're looking at maybe 40, probably $30 though. We make like $5 on that or something. It's not a lot of money. But the good thing about doing a baseline in a controlled setting, there's a couple options for doing a baseline. You can go at your high school, which is great because it's free. You do it in a big setting. But what I'd love to see is that kids are told why it's so important before they do the baseline. And somebody's there the whole time making sure they're not talking with their friend or something. The other thing is what Impact and what the others are now offering is to do online baselines at home. Maybe better than doing it with your friends in a computer lab. I don't know. But that's a little concerning to me because mom or dad might not know exactly what they're doing while they're doing it. Hopefully somebody's watching them and making sure they're doing it right. But the biggest thing is, are the baselines evaluated? When I did them for Gwynedd Mercy College, I did them just for their lacrosse team. And we had 37 the first year. And there were 5 of them that had to be repeated because they screwed up one section or the data wasn't correct, and I found out that the one kid had an exam the day before, and he was up all night, and not the perfect time to do a baseline the next day. Never, ever, ever return to play on the same day. Not worth it. Not worth it if you're 6, not worth it if you're a professional athlete making $25 million a year. Not worth the rest of your life to go back on that same day. Get evaluated, make sure. Like I have here, when in doubt, sit it out. If you're not sure, sit it out. It's not worth it. Even if it's the championship game of your senior year of your high school, it's not worth you going back in the game unless if somebody can evaluate you and make sure that you didn't suffer a concussion. And lastly here, if you suspect a concussion, see a doctor. But if your symptoms worsen or if you develop new symptoms, get to the ER. That's when you need a CAT scan. I think that's it.